All right, so we're going to go ahead and get started now. More people may join as we get going. So Jessica is our presenter today. She serves as the Clinical Operations Manager and as a primary therapist for Healthy Futures, which is an eating disorder IOP treatment facility in Scottsdale. She's a licensed professional counselor and has been in practice since 2010, treating eating disorders. She has specialties in ARFID, adolescent emotional eating, and performers and athletes. With counseling experience at the inpatient, IOP, and outpatient levels, Jessica brings experience in dialectical behavior therapy skills training, somatic experiencing trauma healing, expressive arts therapies, as well as other various styles of experiential group and individual work. Her caring and comforting nature embodies her therapeutic approach. With a background in sports psychology and team building activities, she engages groups and individuals with fun and creative techniques to enhance the therapeutic process. Her experience as a dancer and ballet instructor, oh, I love ballet, in addition to several traditional and non-traditional sports activities, gives her a wide range of skills from which to turn into experiential therapies for individuals and groups. Jessica spends her free time with her family and finding joyful movement outside in nature. That is awesome. I love that. So I'm going to turn it over to Jessica now. Again, if you have questions, feel free to put those into chat or Q&A, and I will interrupt as we go along. Thank you, Jessica.
Thank you. I had to grab my water real quick. Thank you so much for the intro. Thank you everyone for being here. I'm so excited and I'm nervous. So I'm putting that out there because I was told once if you say it out loud, then it goes away. So I'm going to throw that all away here. And I'm very excited to share with you. Seeing the names in the chat and seeing where everyone's coming from. I'm just so excited. I tried to make this presentation cover some eating disorder education awareness information because I don't know who is here as far as the level of what you know about eating disorders. Some of this focusing on trauma and nervous system healing and understanding that. And then hopefully a good chunk of time to talk about some of the strategies and techniques that I specifically use. And some of the things I'll talk about beforehand will kind of set that up as to kind of why I focus in those areas. So yay, let's begin. Eating disorder treatment, particularly with a nervous system regulation approach. I even picked this picture because it feels like flow and fluidity and unsticking and creating, finding those stuck points and creating movement and motion. Like she mentioned, I have an athletic background, a dance background. I do movement groups. So I like flow. I like mind and body connection pieces. So I just kind of wanted to set that tone from the start here. All right. Also, of course, already said disclosures. I'm with Healthy Futures here in Scottsdale, Arizona. And a reminder of our objectives. We're going to identify eating disorders, trauma and nervous system healing, and then some techniques. So, eating disorders, some of the main and basic ones I thought we would start with. I'm going to move a little picture around here. Some of the main diagnoses points up here on the screen, but just to kind of talk about it, the diagnosis of anorexia nervosa, similar to previous iterations of the DSM with respect to behavioral and psychological characteristics involving restriction of food intake, resulting in low body weight often, intense fear of gaining weight or becoming fat, disturbance of body image. Notably, the DSM criteria do not refer to a specific degree of weight loss anymore, right? Again, I just don't know where everyone's at with keeping up on the specifics of eating disorder diagnoses, so want to highlight some of the newest points, but instead provide the guidelines for specifying just the severity of that loss. The diagnosis no longer uses the word refusal, which also allows for more assessment kind of more broadly. And I like to say, while weight, and it's mentioned so much, is commonly a factor, you cannot tell if someone is struggling with anorexia purely by looking at them. Weight can be across the spectrum. People in larger bodies can struggle with anorexia. So again, we're very glad that the diagnoses can allow for that and open for that. The modifiers on there focus on BMI. That's our medical model. And I just like to share, we at Healthy Futures, we like to use that alongside ideal body weight. So the kind of the I put the little formulas under there. And anyone under 5 foot, you subtract 2 pounds, I think is what I read up. So we look at ideal body weight for IOP level of care, and that's what we do at around the 80th percentile for anorexia. Oh, I put a little image in there, kind of slid in. It's very small, so when you get the slides, you can take a peek at it. But it's helping me tie into this theme of, and how does it look in the body, right? How do we experience that bodily? And so this just kind of notices and identifies some of the areas of the body that these behaviors can impact. And so we're not going to focus on that right now, but just kind of tie that into and knowing how this is such a very bodily and physical diagnoses and struggle. Bulimia nervosa involves the uncontrolled eating of an abnormally large amount of food in a short period, followed by compensatory behaviors. These might be self-induced vomiting, laxatives, excessive exercise. People forget the kind of broad variety that can look like. The main changes to know of about these is it reduced from that twice a week to once a week. Of course, always having to differentiate this from anorexia nervosa. It absolutely can go back and forth, maybe across years, but that's important to really assess for and break down for someone to help them think about and notice, well, where are we going to focus our goals on? I wanted to check. There we go. I did find a little prevalence number here. Bulimia nervosa impacts about 5 out of 200 females in the US. A comparison to anorexia nervosa, 1 out of 200. So we're kind of going to go up in increasing prevalence according to some of the research and numbers out there right now. And as you'll see in the little graph on the left, an even larger quantity of, based on the research out there, is binge eating disorder. Recurrent episodes of binge eating disorder, again, very similar to that bulimia diagnoses, kind of those quantities, those per week. And again, just a very common one that we don't see a lot of program services for, and we do have that at Healthy Futures. So really encouraging someone who's struggling with this. They're going to, again, typically seek that medical model first, and then oftentimes we'll kind of finally come to that space of, oh, there's this emotional component that I can work on and heal with. Moving on to RFID, and we'll take a little bit of time on this one. This is where I wanted to spend some time on today. So I'm highlighting this one. One of the diagnosable or billable, right, criteria here, a lack of interest in food. Sometimes commonly heard of as picky eating, a phobic level of food, distinctive quality of like, I might die if I eat this. For example, fear of choking. Or intense internal pain is one I'm commonly seeing, often manifesting in terms of allergies. We were just talking about this in the couple weeks as a clinical team, and it kind of, I feel like it satiates that cognitive dissonance where it's like, oh, I can't eat that, so I'm allergic to it. And it's not completely made up. It's truly the feel and the authentic connection to that. And like a recent example of someone I'm working with where she's like, I always thought I was allergic to it. Like I believed it, I knew it. and she's been doing a lot of work, and she, we were able to confirm that there was no previous severe or dangerous allergic response, and she tried it. And one of the things I love working with people with ARFID, is that they're like, oh, and I loved it. It was delicious. I can't wait to have it again, right? So just to kind of give you some different components of how that looks. Hello, everyone from everywhere. I love this. This is exciting. Let's see, where? So the field of treatment with ARFID is different, in my opinion. And I think when I've been speaking with more and more people about this, it feels the same. They love that they can now enjoy the food. And yes, sometimes ARFID presents from a trauma or an actual negative experience with food, choking on one. Having it just be combined or linked with a reaction, maybe it wasn't because of that. Maybe it was just a coincidental piece. But when our nervous system, we're going to bring that in now, was hyped or set up for that, it connected those two, it linked those two and created a little trauma bond there. And the more and more of those we have, then the more pattern we create with that. Another distinctive feature with ARFID is the criteria say no body disturbance. And I like to just challenge that a little bit. They don't have the same body disturbance in regard to, like we see with the other traditional eating disorder diagnoses, a fear of gaining weight or a fear of a certain number or anything like that. I do feel like anecdotally there's a body disturbance where they feel hyper aware of maybe how thin they are, how much weight they have lost, body judgments from others. They do feel that. So I just like to kind of personally put that in there, but it is distinctively different than the fear of gaining. So that's another way that we can differentiate when there is more clear differentiation between the two diagnoses. And yes, just like any mental health diagnoses, there's going to be the times where they overlap and they combine. We'll see a little anorexia traits, and we'll see some ARFID traits, and we're going to kind of work through that. And sometimes they do that same thing that we see, where one will rise or one will come up, right? So just another thing to keep in mind. And then the other point I wanted to say with ARFID, and again, this is part of why we were very interested in sharing this information with you now and in the current times, is we're seeing this, and again, very tightly connected to OCD. And so, yes, thank you, Mia. I didn't write that out. Thank you. Avoidant restrictive food intake disorder. So we're seeing this, like, again, and notice how it matches that obsessive compulsive. There's the fears, the fear of death, the consequences or fear of consequences that we see aligned with that and connected to that fear of food. So we're seeing a lot of those together. So we're working on some things to implement. I don't think I have it later in the slide, so I want to say it now so I don't forget, like some of the new pieces like RODBT, working on the rigidity and restriction. All right. And then, of course, we have our other specified ED, PICA. There are 2 codes for children and adults and rumination. I'm not going to spend much time on them, but they fall under the category. I thought I would mention them. Other things that are more colloquial and not necessarily in the DSM or given a true diagnosis, you hear the words orthorexia, like compulsive ingredient list checking, healthy food concerns, cutting food groups entirely, still having those obsessive thoughts like, when's my next meal? What's that going to look like? Planning my whole life around that. So you're still going to, of course, take a look at the symptoms and as they accumulate and present itself. And then I again like to really mention when we talk about eating disorders, to know it is all shapes and sizes. It is gender inclusive. How nice of it. Males and females, while there are some predominance in the sense of research and numbers towards females, one of the things that I love and appreciate about where we're at is we do have programming for all, and hopefully all are seeking that help. All right. Now, some trauma talk, trauma and nervous system regulation, right? I love this quote here. It actually popped up for me today. I was so excited on one of my social media feeds. When all you know is fight or flight, red flags and butterflies all feel the same. Felt like it really matched what I want to continue as a theme for this presentation, which is the body and the nervous system connection, right? And how it feels. I talk about actually butterflies when I'm explaining things to someone. I talk about these gut instinctual body responses, right? Where we talk about, oh, we say, I have butterflies in my stomach. Well, that's the highest number of nerve endings on the inside of the stomach lining, right? And no wonder when we have an eating disorder and we have food and nutrient challenges, oh, it's going to be pretty dysregulated in there. And we're going to talk about that a little bit more as well. Or we talk about gut instincts, gut feelings, right? I like all of those little metaphors and connections. They just seem to really land with me and with people. So I really liked that popped up today. So trauma and your nervous system. This is my little, those of you that are familiar with SE, these are my little red vortexes, just my little, I don't know, Easter egg drop there. Trauma comprises our ability to engage with others by replacing patterns of connection with patterns of protection. So I like looking at Porges and Levine here for my kind of where I come from in a nervous system and trauma healing place. I'll let you read the second quote there. But basically, knowing how trauma impacts our engagement and connection based on historical patterns. So obviously, it can be hard to identify how these are connected, but also hard to break the pattern. I really enjoy metaphor work. This is something I've been growing myself. And so one that I like to share when I'm educating either a patient or working in general with neural pathways, right, in general, is we're forging a new path through a jungle, right? You have a known path through the jungle. It might have tigers and alligators. It might not be a very fun path to go through, but you know it. And you know where they are, those dangers potentially, right? And creating a new path, going through this healing process is like taking a machete and hacking a new trail through the jungle. It remains small. It's uncertain. I don't know what's going to pop up behind the next leaf, right? Ah, wow, right? It's a bit scary. And it's not really well worn. It's something that is hard every time I turn my DBT people out there, turn the mind and move to that, right? And that previous path in the jungle that I know is still there. I keep sliding down it. I keep turning towards it when I need to. And I like to help people understand that's how easy it is and why it's hard. It's not just as simple as this. Like we say, there's no exact magic wand or pill or snap the fingers. It's this work, right? But we keep forging the new path. We keep doing that hard work. We keep getting that support and having someone guide us through. And the new one will start to form more clearly. And the old one, just like a jungle or think of a hiking trail, will overgrow, right? You see people forging new paths off hiking trails, and I don't recommend that. I'm a nature person. Don't go on the off trail. Stay on the trail. But for this metaphor, if we create a new trail, it will get more worn. It will get easier. And that's what I like to share with everyone. But we have to break these patterns, and we have to do that work. So again, another wonderful little image that I do use in either groups or presenting with someone is that nervous system regulation is often not a cognitive process. We can use amazing cognitive skills with it. But how do we know that, right? I love this little, the iceberg image or the mountain that we can use in various areas, is that our mind has this much information and our body, our nervous system holds so much, our tissues, our cellular structure. The human brain is an intricate organ, and it contains about 100 billion neurons, 100 trillion connections, right? And it's our command central. When survival is threatened, and I found this little statistic here, when less than a 1/500th of a second, your brain is able to scan that history, right? We know how this primal part of the brain works. It's like a highway. It shoots and it's a little bit slower coming back, right? So that's where we get that instinctual reaction. And it chooses the relevant data and it comes up with the greatest survival probability outcome, and we go, right? That's what our brain does, and because we hold all of this. So in comes polyvagal theory, right? 1994, Stephen Porges introduced the polyvagal theory based on our evolutionary neuropsychological understanding of the vagus nerve, this primal part of the brain, lizard brain, whatever name you may have for it, and its role in emotion regulation in our daily life and functioning, social connection, fear responses, right? Since then, we have a more understanding of trauma and recovery and providing a physiological explanation for a trauma survivor's experience and a heightened nervous system experience. And this is my fun little image for this, for kind of explaining this, is we have our sympathetic nervous system, that fight or flight response, right? The mobilization, the first line of defense. This is located on the spinal cord, and I'm going to have some other pictures coming, but I have the goofy picture first, and then we'll go to the more anatomy type picture after this. We feel it in an increased heart rate, shallow breath, muscle tension, and it mobilizes the body, right? And then we have our dorsal vagal response, shut down, cooling, freeze. You've heard fight, fight, or flee, freeze. It's the immobilization. It's that second line of defense. It's in that diaphragm, that gut viscera. So to tie this to eating disorders, think about if we're frozen, if we're having to go through these responses and we have this freeze response in the gut in particular, we're not digesting, there's malnutrition, we're not optimally functioning there. So again, it is our last resort, but when we've done fight or flight for so long and we out of threshold, we uncouple and we freeze. And then ventral vagus, right? This is where we want to come back to. If we think about back to front, social engagement, communication, it's in the face, it's in the throat, it's in the chest. And then that's your rest and digest. So if we live in those other two, we're not giving ourselves enough time to do all that in the body. So here it is in kind of more of that anatomical bodily way, that social engagement, the face. This is why we're super excited about RODBT, like working on facial expressions and changing our responses in that way. Play is kind of that hybrid of the ventral vagal and the sympathetic, kind of activation in a nice way. Intimacy, getting that ventral vagal and dorsal, getting down into that gut and core area. This is just, again, so we can kind of connect to the body. Again, that's what I like doing, is where is this in the body? How do we experience it in the body? So fight, that sympathetic, that safety mechanism coming on. It's always right at the base of the brain there, right? That's where our control command system goes, send the system warning out, prepare. And flight. Also that sympathetic, but kind of moving down the spine a little bit more, getting ready, getting prepared for whatever we need. And freeze. Kind of moving down into that sympathetic and that dorsal, right? Again, we talked about that gut freezing is kind of in that central area of the body. And shut down. Okay. I covered what I wanted there. Yay. So, what do we do with this now that we know that? And we can do this. I occasionally get ribbed for my optimism. I've even had patient stories where like, you're bubbly, you're like so excited. And I'm like, I am, because I can't wait to teach you some of this. I can't wait to bring you relief. And so I like to just frame things in that way, right? What do we do with this? We can do something with this. And again, I'm going to tie it into this a little bit tighter to what we're seeing. Now, any and all of these strategies, you may be familiar with some of them. They may be some of your favorites or not. But so this is again for all eating disorder diagnoses. And I am going to lean a little bit heavier on the RFID because this is kind of newer, right? And not newer diagnoses. It's been around, but it is a bit newer as far as actually being a label or identifier, but even newer in the sense of quantity of what we're seeing. So keeping that framework in mind, we of course start with a lot of the where do I feel, very DBT based as a provider myself and as a practice at Healthy Futures. Hopefully, I started with one that I presume will be very familiar, is the emotions, right? Can I even identify them? Do I even know what they're called? The color wheel is a favorite as well among a lot of us. And then, like I said, I like to connect to the body. Do I have any idea of where it is I feel in my body? Oh man, I forgot. I was going to have an example prepped when I was making this presentation. I was on this slide and my daughter walked in and she was like, "What's that?" She's 6. And I was like, "Oh, it's just a little coloring." She's like, "Print it for me." I do that all the time. So I printed it for her and she just did a beautiful job. And it's just so cool. I love this activity in groups and with people. But even my daughter, she's a mover and a groover. Her legs are always moving. Can you guess which part was colored completely in? Her legs. And she brought it back to me and I just was like, "Oh, yep." There it is. So if you don't use this one, I really do enjoy this one. And it's a nice intro to connect to the body. This is a lot of work that we do across eating disorder work, right? Is we're at a certain point, and especially at the IOP level of care, when they get to us, we're up to here. We're disconnected to the body. We're not listening to it. And out of a protective nature, right? Out of a functioning nature, often at a point. And so the work being slowly titrated, moving back into reconnecting with the body, not so that it's not slammed and woof, takes us over, but just this like curiosity, right? I love that word. We use it a lot. Getting curious about where it is. So let them pick their colors, let them put it in here. And then the beautiful part is, of course, expressing it, noticing it, observing it. And then we start to connect to those sensations in the body. All right. Another one of my favorite bodily or physiological based intervention. And again, this is because we're knowing how much is impacting the body and we're trying to reconnect to the body. All my DBTers out there, the tip skill. I actually just chatted with someone yesterday. She's like, "Do we have ice packs in the freezer?" And I'm like, "Yes, we do. Of course we do." We are going to actively practice these with someone. We're going to, those of you not familiar with TIP, it stands for temperature, intense exercise, or I like to call it a burst of exercise, paced breathing, and progressive muscle relaxation. So temperature, it is the dive response, right? Remember those physiological sensations. Maybe in particular, just to give it some eating disorder context, I'm thinking about trying a new food. I'm challenging the way that I eat. I'm going to eat with someone. It could be a myriad of things. And just to kind of keep it in that framework, those might be some examples. And I feel the activation, heart rate going up, shortness of breath. That means my heart's pumping, my blood pressure's tightening, and it's getting hot. Woo, cortisol release, right? Inflammation. So we create the dive response. And in, DBT, traditional DBT is a splash, cold water in the face, right? Ice water, put the face in it. And the face in particular is important. Why? Because again, that's our communicator, right? That front response there, that social connection, that parasympathetic, right? Okay, cool it down. And again, to come back to these phrases and these metaphors, like, just cool it. Ooh, just cool it down. That's how I like to teach it. But an ice pack works to me. If that's a very accessible one, right? Hang on, I'm going to go get a bowl of cold water right now. I might have an ice pack or frozen oranges, big favorite, right? In DBT. But Put it on your chest, put it on the top of your head. That's where we release a lot of heat, back of your neck. And then very, very much so, right? We talked about the gut being that area of high sensitive nerves. We can put it right there. Ooh, and cool that down. Bring a physiological response that says, I'm okay, I'm safe. And then our mind can come on down with it as well. Intense exercise, a burst of exercise is what we like to call it. Or I use it in those terms to make sure we're not triggering any kind of eating disorder or over exercising piece, right? This is not suddenly permission to go back to that over exercising behavior. No, this is a burst of energy, right? Just a little like run in place, couple jumping jacks, or a quick play, quick bout of put on your favorite dance song and dance to it, right? So this is what this is about. And again, we're tapping into a physiological response. We're activating those kinds of things in the body and creating this up and over the sympathetic, parasympathetic response. Same thing with paced breathing. We're going to slow down the breath. We're going to do a little breathing experience. I like experiences, so get ready. I saved it towards the end so that, maybe it'll help keep us awake too as we go. But some paced breathing, obviously, I hope many of us know, or most of us use some fabulous breathing exercises and techniques. Like I said, we'll do that next. And progressive muscle relaxation. So I thought maybe we could do a quick little brief intro to this. If you are interested or trained in DBT, there's that whole fabulous page in the book, in the DBT book, that walks you through a true progressive muscle relaxation. But I really encourage you to try this if you haven't done it with me right now. Is progressive muscle relaxation actually, it creates, again, physiological, body-based, an tension, right? We're going to tense up on purpose. We're going to create a rise to match what I'm feeling. And then we're going to create a relaxation. And the paired part, right? Sometimes this is called paired muscle relaxation or progressive muscle relaxation. I've heard both. We're pairing it with that cognitive piece of relax, or whatever word you like, right? Release, breathe. It's okay, right? Relax. So I'm going to use the word relax. We're going to do just large muscle groups. The actual progression of this really breaks it down a lot more. But I want you to tense your face. Make a little tension, make a little squeeze the eyes and the mouth. Breathe in, and when you exhale, relax. Relax the face. That feels better, right? And if we were to do the same in the neck and shoulders, we're going to squeeze that up. We're going to breathe in and have that tightness and tension. We're going to think the word relax. As we let that go. Do you already feel the sensation in the body differences or the tingling that's happening? This is what you want to kind of point out or bring up to those that you're working with. And then do the same with your arms. Stretch the arms or tighten and squeeze the muscles. Breathe in. And exhale, release. And then we move down the body. We're just going to do a complete piece because as a person who loves SE, I like completion. So just squeeze the center or the torso of the body, the chest. This can be outward or inward, whatever feels good. Breathe in and release. Relax. And you do want to make sure we create intentional pauses in between. We want to let the settling happen. This is that up and down little pause at the bottom, creating regulation, right? Squeeze and tense the legs. Again, I'm going in large areas, breathing in and relaxing with the release. And really feeling that bodily shift, and maybe even then it can shift the mind a bit easier. Yes. So I like all of those. And then we talked about breathing. Here it is. Obviously, again, the physiology, breathing goes up and down the spine, goes up and down that nervous system. Remember, that's that image of the body. It goes right there. So this is where we're creating that motion, that movement, that fluidity. Remember that from the beginning. That's what we're creating in the body. So I like to share that when we're doing these breathing techniques. Tons of fabulous apps out there. I love using apps. I love recommending it. Oh, and they don't pay me for this. I just really like these. They're called Calm strips. If you've ever heard of those, they're as you may or may not be surprised, doing this kind of work in particular, eating disorder work, ARFID work as well. We see a lot of autism spectrum. We see a lot of sensory pieces. And so I've been building up my fun tools in that way. So if you haven't already heard of Calm strips, look up that. They have the sensory pieces, but they have circle breathing and square breathing in these strips with different textures. So it's really cool. I like having a few and handing them out. People love putting little decals on their phones and things like that. But circle breathing, excuse me, to follow these arrows, we're going to breathe in, we're going to hold, we're going to exhale. And with a circle, I like remembering the number 3, right? 3 seconds, 3 times, 3 sets, lots of threes, but breathing in for 3 seconds. Hold, 2, 3. Yes, calm strips. I love them. And exhaling for 3. Doing the circle 3 times. The magical number 3 does come from some studies. I learned this in my sports psychology pieces as well, is that that number and that quantity in particular, this is why I like circle 2 as well, is it creates a heartbeat shift and a blood pressure shift. So again, coming back to this physiology of this amount of breathing can make that change. And if you love square breathing more than circle, awesome, right? Whatever works for you. I just changed the number from 3 to 4, right? 4 in, 4 at the top, 4 out, 4 at the bottom. So a little bit more length at the top and the bottom. I've heard different pros and cons or various perspectives on where to put the holds, right? Especially in the circle. Do you put it at the top? Do you put it at the bottom? Personally, I say whatever works for you, whatever you notice works in your body. I have also heard different things where holding at the top, does that create more tension and activation? Just notice that. Holding at the top, does that actually kind of allow it to float and hold the oxygen in? So there's good benefits to that. And then we exhale that all the way out, right? So just know what works for you, know what works for your person. Sorry, I'm several weeks off of an illness and I still have a cough that pops up. And then diaphragmatic breathing. So knowing the physiology is important for this one too, is knowing that the diaphragm is that kind of balloon-like texture structure at the bottom of the lungs. We want to fill that up, right? When we're working with kids, we're filling up the balloon in the belly, right? And I also really like to talk to my patients about, especially nervous system, heightened people. They're always in that fight or flight response. They're always in brake and gas pedal, go, right? Zzz. So that first breath is not going to feel very deep. Oh, I can't access it. That's frustrating, right? Yes, we're going to do more than one. We're going to do at least 3. And we're just going to notice in a loving, gentle way how it expands a little bit each time, how it grows the second time, how I can go a little deeper and how it opens up the third time. And that's going to, again, contribute to our nervous system regulation. Okay, I think that's enough on breathing. We've breathed. And I want to point out, I'm continuing through some of my favorite techniques. Again, this is for all eating disorders. This is to focus on the nervous system first. These are not all in one session. These are spread out over the course of sessions. This next one I have in front of you, these orienting and grounding ones, I start them very, very early, potentially in that first session, where we're really focusing on orienting and grounding. Now, again, you may have your favorite grounding and orienting skills and techniques, but I just wanted to share a few that I have learned and that are my favorites and go-tos that I've really found that people enjoy. Is rainbow orienting. So again, a little focus on orient, the word orienting first. Orient to your surroundings. Get to know it. It comes from And I was taught this by my fabulous mentors, Mia included in that, who's here today, is the somatic experiencing concept of there's no snakes and tigers in the corners of the room. I've checked. I see what's around me and I'm in a safe space. So these are just those tools and techniques to get us there. And as I was taught, and I make so profoundly clear to everyone, is you have to turn your head. Why? It's that base of the spine. It's getting and tapping into, remember that this vagus response back here, that fight or flight is initiating from right here. So if I'm changing and orienting my head, and I'm not, you'll see this patient, right? And they'll use their eyes at first. And I'm like, nope, that's cheating. We're going to turn the head. So we're going to do some rainbow orienting. I would love, again, this is where I like to kind of get, if you wouldn't mind, those of you who are on here and ready and willing to jump in, we'll throw them in the chat here. We're going to do a little rainbow orienting. So we're going to start with, and you got the colors in front of you. We actually do start with red. And here's a theory behind that personally. Remember that little red circle, red vortex? This is where we're at probably. Woo, I'm in that trauma. So we're going to meet you there. We're in red. We're looking for red. We see that red. So can you throw in the chat some fun things in your environment right now that are red? Like, for example, I have a cute little red AirPod case. So go ahead, turn your head, and find something that's red. Throw it in the chat, if you will, just to get engaged. Magnets, a dog toy. Love that. Oh, roses. How beautiful. Look at all these. Nice. And now those of my SE providers out there, I'm going to do this pendulation work and we're going to go to blue. Woo, we're going to go to blue. What's blue out there? Right? Red tends to be that trauma. Blue is that soothing, calming. A tissue box, a stress ball, a hat, a cup. I love it. We're going to stay blue a little bit because we're going to get curious about what that looks like. We're going to go green. What do you find around you that's green? Nothing. Oh, we'll have to get you something green. Plants. What about yellow? Move into yellow. Keep turning that head, keep noticing. And also, just like any mindfulness strategy, as we know mindfulness, we're looking around for longer on purpose. We're looking deeper. The colors also get a little bit harder as we go, or less common. And that's part of my strategy as well. Orange. Orange would be next. You have a carrot. That's awesome. Orange Tic Tacs. Perfect. And then again, like I said, part of my strategy is I go a little bit harder. Do you have anything purple or pink? Maybe that's not too hard for this crew, but sometimes that's a little harder. What do we have? Headphones. I like that one. And then I'm going to go even further into brown. Then I want you to keep noticing what's happening in your own body right now as you're looking around your space. Do you feel anything? Do you notice anything? And then I would move into black. And I might even move into white. Right? So I'm speeding up more for the presentation purposes, but I would keep it nice and slow. I would spend a lot of time on this with someone, not too much, but enough time for them to land, to look, to search, right? The more we do that, the more we're communicating. Awesome. Tissues. I love that. Good. So if you haven't done rainbow orienting, add that to your toolbox. I love it. Really fun with kids, really fun with young ones, and the adults love it too, right? It brings out that fun and playful side. And if you remember that image, right, of the body and the area of fun, we're moving back to this space that's a little bit more like, oh, it's activated, but it's playful, right? So we're going to be able to access that a little bit more. So rainbow orienting, 5 colors at least, right? If you're like, oh, I can't do that many colors, that's way too much. 5 colors at least. I like the number of 5. I think it's a pretty magical number across the board. So at least 5. And then each, like kind of every session, I'm going to check in with that. Hey, did we practice that at least once somewhere? Maybe they had something that they were going to. Oh, yay. I'm glad that it's new to some. Maybe they're going somewhere and they're a little nervous about it. They're a little stressed out about it. And so it's like, oh, well, perfect. Let's try the rainbow orienting. Maybe we're at that. We're already, and again, usually I do rainbow orienting pretty early. So we might not be right at a meal challenge, but maybe they are, right? Maybe we're working on a food. Let's rainbow orient first, right before we sit down. Let's use these techniques right then and there. Other orienting and grounding shapes. Yeah. So you can get pretty bored of looking for colors all the time. So had to come up with some more activities. This is anything, right? This can be anything. So just create some categories. Find some shapes. So if you want real quick, look around. Do you have any squares? Do you have any circles? I usually try and do 3. Like, can you find me 3 circles? Can you find me 3 squares? Can you find me 3 rectangles? Can you find me 3 triangles? Notice I'm trying to get to 5. So then I'm like, can you find me any diamonds or hearts? That's pretty easy to do in our practice because Healthy Futures symbol is a heart. So I was like throwing that one in. I might even add squiggly, wiggly patterns. Okay, what about straight lines, right? Shapes. So increase that so that we have enough time and enough practice of engagement in our surrounding to do that. Directions. 3 things to your right, 3 things to your left, 3 things in front of you, 3 things behind you, right? Why behind you? Again, just to double check. There's nothing behind me. Okay, right. So have fun with that. Get creative with all the different ways that we can play with that. And then I put the 5, 4, 3, 2, 1. It seems to be a pretty social media popular one out there, so I didn't want to ignore it, right? Hitting those 5 senses, 5 things I see, 4 things I hear, right? 3, 2, 1. I like ending with touch in particular, again, because we're getting to that physiological touch piece. So that's a personal preference, going through the 5 senses as well. Okay, just checking the times. And I wanted to give you one more. I'm going to credit, and Mia, if I'm wrong with my credit, but I remember Dr. Kim DeRay gave me this one. I don't know if she made it up or got it from somewhere else, but we could ask her. 3 in, 3 out. And if you haven't heard of this one, I've talked about flow, right? We've talked about creating movement and flow. 3 in, 3 out is pendulation, movement. So we're going to use the chat feature again. We're going to get into it to practice it. This is how I might give it to a group. But obviously, if you're just with one person, you're having them do all 3 as well. But we always start externally. Why? Because that's probably a little safer. Again, tying back to eating disorder work and the connection with trauma and nervous system work is the body is typically not as safe. So we're going to start externally and we're always going to end externally. So just remember that when you're doing this. So go ahead and chat me 3 things that you see in your surroundings. And it doesn't have to be see, that you observe. Things you might see or hear or feel or touch. Your phone, a pet. I was hoping a pet might be in there. Sound machine. Awesome. Yeah. So now that you've identified something externally, I want you to identify 3 things inside, internally. Do I have a headache? Am I feeling a little hot? Is my stomach grumbling? Is my right toe hurting? Right. And I do tend to have to, we call it menu it, right? For some at first when we're going in, right? Because we may not have connected as often there. What are you guys noticing inside after we're doing all this grounding and all this orienting? Yes, heart rate, some arms, some backs. And then what we're going to do is we're going to pendulate back out, 3 things out. So you don't have to chat these, but just you would move back out to the external environment, back in one more time. That's the hardest one, right? We've already picked up 3 things on the inside. Can you actually come up with 3 more things internally? You can. Challenge that, right? We're flexing those muscles, we're connecting, and we're tapping in to it. And again, don't hesitate to give some examples. Nice. Yeah. And then, like I said, come back out and end externally. So if you've been doing this with me, come back out to the external, connect with 3 things in your observation. So one more, that was one, the last little technique or tool I wanted to throw your way. That's very nervous system or body based that I really enjoy when we're doing this kind of work. And then I'm really doing a lot more of this touch work. So I wanted to share a little bit more about familiar with somatic experiencing touch work in particular. I like to always caveat, to make sure you have some training and support in this, that you have separate informed consents for this, because this is very different work. If you are interested in this in particular, like the Somatic Experiencing Trauma Institute is where I do my training through SETI, and getting some of this touch work, but also with my lovely mentors who gave me so much experience and knowledge and awareness and the space and the support to do this. So I'm doing more and more than I've ever thought possible of this touch work, and it begins with kidney adrenal work. And I put a little picture up there, but the way that I like to explain it is our nervous system, when we're activated, right? We've talked about all these bodily responses. One of those responses is the release of cortisol from the adrenal gland, right? And I imagine it as this little pump firing, boop, boop, firing off cortisol. And this is our fight or flight or freeze response, right? Especially the freeze, where, remember that metaphor of 1 foot on the gas pedal, 1 on the brake. I feel it, but I'm stuck, because we're feeling all that cortisol and that inflammation rise. And what it gets activated by the kidneys, right? The kidneys, they travel up and they get the adrenal gland firing, and it's going boop, and it's just going and going and going. So with one of the first steps of touch work is some kidney adrenal work, right? We're going to give the body, right? All these strategies and techniques are like, hey, body, it's like a trick, but it's not, right? I'm going to tell you, we're okay right now. Yeah, we have a history and we have a pattern and we have things that have activated our system and response, and we're going to validate that. That's important too, right? Validate that. And yet I can't figure out how to turn it off. So we're going to start with the body. We're going to start turning that off with the body. So we're going to try, and just like by putting a hand under the back, giving it, and for some it's about energy and intention and that kind of work, but there's also, right, we know that there's this co-regulation work that happens. So this is why it's also so important to do our own work. But we're going to try and bring that kidney down and shut the adrenal gland off, if not for a moment, perhaps for an hour. Maybe it'll go for a day. And that's the idea, is we do it more and more, and we get the body to relearn, and we reteach it that idea of, I don't have to be. What would it be like if I didn't have to be in fight or flight? And we teach it in a way of like, well, what would that feel like in the body first? Oof, shutting off some of those adrenal glands, lowering some of that cortisol level, perhaps, right? Some of my My current work is people are, oh, I hope it brings my pain response down. I hope it, right? That's what we're hoping to create, and creating a longer response and a longer trust in the body of, oh, that would be okay. Tends to also feel like really tired because we're running. What happens when we shut that off? Oh, fatigue, right? So making sure these sessions sometimes can be much longer because we need to create a lot of space to come out of it, or make sure that there's a lot of safety in that way. So I just wanted to throw that in there. Again, caveat of the right training and the right mentors and the right support and the right pieces around that. But that is some of the work we're doing. And then comes the food. I thought this was an eating disorder presentation. No, but it is both, right? We're going to do all of that first. I'm not going to not talk about food. I'm not going to not work on that in some way, but we're going to start, especially maybe with RFID in particular, we're going to be okay with some safe foods at first, because we're changing the nervous system response. We're changing patterns. We gotta get settled with that. And then we create more opening, more capacity to create some of those food changes. This is where we can start to implement maybe some of your exposures or some of the other strategies or techniques or whatever modality you use in that way. But we feel very, very, very strongly with, we're going to support that change first. We're going to do so much of this nervous system work, right? And again, I'm going to bring in the somatic experiencing piece of lots and lots of blue and a little bit of red. Lots and lots of support, lots and lots of nervous system work, and a little bit of the challenge. And then that can kind of grow, right? We'll see that activated person repeatedly at the beginning, and then all of a sudden they're like, guess what? I did a challenge this week. What? We didn't even talk about one. We didn't even say we should do that one, right? There wasn't any pressure to do that, but they just felt capacity, and they're exposed to it all day, right? We're exposed to the things that we're afraid of in the regards of food. That's, we talk about eating disorder treatment, and one of its difference is we're relearning a relationship with food. We can't just avoid it. We can't just walk away from it. We are relearning a connection with exercise and movement. That's near and dear to my heart, right? My sports psychology background, my dance, my movement. I want it to be in your life. And we have to learn how to do it in a different way. And sometimes that does mean with various, whatever our challenges are, stepping away from it first, changing the pattern before we re-enter. Same thing. And again, I'm making this presentation a little heavy on our more highly seen RFID pieces. Same things before we challenge the food back in, before we make those changes. Then we're going to implement all these little strategies, and could create a whole new thing on this, but food graphing, right? Especially our sensory people and our like colors. We're gonna do textures. We're gonna just talk about things like that at first, right? And when we notice this nervous system activating, when we notice it in the face and the body and the fidgeting and the curling back into the corner, let's do some orienting. We're gonna bring that back down. And then, oh, that was enough for today, right? And then the next time, okay, hey, remember I pulled out this sheet. We started making a little list. Are you ready to come back to this list? Are we ready to kind of be curious about what this is? Right now I'm working with someone where she liked the idea of making little circles, like plates. It's really cute. And I just really encourage creativity with this, right? And so she has a little plate of the safe food, and we put it on the piece of paper. And then we're like, okay, what could come near the plate? We're not dealing with food yet. We're not touching it. We're not looking at it, but we're just going to put the name on a piece of paper. And she's like, okay, this can be on the side plate. And we'll put it there. And then and you're helping, and you might come up with a really, really tough piece, right? I'll be like chicken. And she's like, nope, that's way over there. That needs to be in the other room. Okay. We're going to put that on a piece of paper, fold it up, and put it way over here. That's okay, right? We're going to, and then we're going to breathe. We're going to use one of those techniques. We're going to bring it back from the back to the front into the body. So then that's when we do all that. Again, whether that's ARFID focused, whether that's, anorexia, whether that's binge eating disorder, right? They're stuck on their routine foods. They're stuck on their favorite binge foods. And okay, we're gonna try something new. Yeah. We're gonna still do that same work across the way. And then of course, I have my little note to remind me, with your dietitian. This is one of the reasons why I love working in a practice. I love working with a group of people. But if you work at the outpatient level, please, please, please work with your dietitian as well, right? They may or may not have their own approach to this or this pieces, but there are some amazing, Sheila weighs ours right now. She does an amazing job at this real slow titration. She even got me the other day where I was like, oh, how about this? And she found one step in between, baby steps. Tiny steps, right? Oh, you know what? The easiest place to access is the food group of fruits. Okay, that's fine. Let's try a new fruit. Let's do these techniques we've already practiced a few times in sessions before we try it, as we try it, after we've tried it. And then we're going to talk about it, and then we're going to work on it. So yeah, we're going to gain comfort and confidence. We're going to challenge the old patterns. We're going to forge the new trail through the jungle, if you will. Back to my metaphor there. Yes, thank you. Just reading the comment there. Okay. I went a little quick, but leaves time for lots of questions, maybe. There's my references. Here's my Healthy Futures piece. How you can contact me. And of course, like Debbie said, we'll be happy to share the slides. Hoping that you got a nugget out of this. Yay! This is awesome. It is awesome. I really enjoy this work.
This is so cool. Do you want to, I don't see any questions at the moment, which is amazing. So that means you did such a great job presenting the material. I absolutely love that. Do you want to talk a little bit about like where you guys are, what you do? Let's see, and somebody wanted to go back to the slide on references. And I'll send this also out with the CEU certificates too, so you'll have it. But do you want to take a few minutes and just talk about Healthy Futures? What do you do? How do you do it? Insurances, connecting, how does all that work?
Absolutely. And thank you. So yeah, Healthy Futures is primarily IOP level of care for eating disorder treatment. We have programming for teens, adolescents, and adults. We are also gender inclusive. And we have different tracks, right? So one of the things I like about Healthy Futures, our favorite catchphrase is structure with flexibility. One of the things that we like to do, Mia does most of our assessments and intakes and takes a look at, well, not only what are we looking at diagnosing wise, so then therefore we have different groups and milieus and tracks, if you will, that are maybe more of the traditional anorexia, bulimia treatment, right? Some of those evidence-based pieces, DBTs in all of our programs. But we do have separate emotional eating, binge eating track and programming as well for our adults. We have occasionally had that for our teens as well when we have that. Healthy Futures likes to meet the need of the community. So whatever's presenting itself shows up. Our teen programming in particular also has a parent component. We feel very strongly about teaching the whole family the DBT skills and some of the just education and support around it. What's the DBT book? I see that one. The DBT book is reference number 12. It's Marsha Linehan's DBT skills training handouts and worksheets. If you haven't done any DBT trainings, find a CE event, go on to, what is it, Mia, the tech, what's the website for her? If you could put that up, that'd be lovely. Behavioral Health Tech?
Yep.
Yeah.
I think it's just behavioralhealthtech.com.
Okay. Yeah.
What's the thing.com?
behavioralhealthtech.com.
There we go. Cool.
Yep.
Yeah, thank you. And so I see a good question I want to jump to, but also saying, just to kind of wrap up, adults, teens, DBT, and very somatic experiencing based program. We have a lot of fabulous providers, some with EMDR and ART training as well. So love just kind of really encompassing this food, behavioral, and trauma pieces, and yes, insurance based as well. So we accept most major insurances. I think that covers some of those bases. Andrea, as someone that fears throw up, I was hoping this would make me feel better to work with my clients with these disorders. I have someone with emetophobia right now who is doing some great work around that. And yes, it's this, like, that's a tough one. We are really working on nervous system, and then some of those kind of OCD-like patterned out practices or approaches to it. So yes. Good question.
Awesome. Well, thank you so much, Jessica and Mia. And they also have a therapy dog, Ted E. How I met
Yes, we
Mia
do.
is that we were on a Zoom and she introduced Ted E. And I love dogs. Anyone that knows me knows I absolutely love animals. And so I went to Healthy Futures to meet Ted E and learn so much about what they do. So animals are my kind of connector and what makes my heart work. So it was very cool. So, oh,
I
there may be one
see.
question.
Yeah,
Oh,
I see an ARFID question. I sometimes have clients that wonder might be ARFID, but might be food sensitive. How might they differentiate that to know if they need IOP or not? I think if I were to answer that question, I see the word food sensitive.